Literature revealed this for Burkhardt found that the inverted pear shape at Glenoid lead to high failure rate after soft tissue stabilization. Many publications reported that the size of the defect does matter, which guide us to plan for a proper ablation, which size really matter for a Burkhardt repair. We accepted that 25% of bone loss could lead us to failure if we perform only soft tissue stabilization. Latarche or glenoid reconstruction seem to be more suitable in this group of patients. Nowadays, the threshold is lower to 17 to 17.3% and 13.5% in contact or collision athletes. CT scan is the most appropriate tool for bone defect measurement, which superior to the MRI. Indication provide for patient complaining about mid-length instability or visualized bone defect in plain radiograph. In 2018, JAOS review article proposed that the algorithm for management of bone defect. Glenoid bone graft recommend in patients with more than 25% of the bone loss, and after that, patient group is between the 13.5 to 25% bone loss, but have the high risk patient or got off-track lesion. Even various technique bone grafting in the glenoid discovered. Today, we will focus on using the distal tibial allograft for glenoid reconstruction. Dr. Matthew Proverser first described this novel technique in 2009. He reported good conformity with humeral head and roll graft resorption. He used just only the lateral side of the flesh distal tibial allograft for anterior glenoid reconstruction. In 7 years later, he published good functional outcome and improved in range of motion after follow-up patient for 4 years. His work still has some limitation following male dominant. There are some revision surgery which could follow to inferior of the functional outcome, and there's no comparison technique. And also they show just only the short radiographic follow-up. This technique has been supported with better biomechanics study when compared to latarche, when arm position is in 60-degree abduction and in elbow position. This technique provided by Dr. Provencher. He done it in the open technique, set the patient in the beach-style position, open in the deltopetroral approach, and open the subscapularis in L-shaped capsulotomy. After glenoid rim preparation, the graft will be prepared, and he used the PRP for soaking in his graft for 10 minutes for improving the graft viability and improve of the healing of the graft. Then he fixed his graft with a screw, just a little screw with washer, and use of the high tensile strength, tie with the screw and use it for subscapularis repair. After that, the patient will following the rehabilitation with a limitation in external rotation not exceeds the 30 degree in first 2 weeks. Contrast to the original one, the arthroscopic technique proposed by Dr. Ivan Vong. He used a semilateral decubitus position and do just only all arthroscopic technique. But for the distal tibial allograft, he used just only the posterolateral part of the fresh distal tibial allograft. The graft site he prepared will be in the 10 to 15 millimeter in AP diameter and superior inferior in 25 millimeter and thickness just only 15 millimeter. For graft passage, he used the far medial portal, which used visible pores and called the Halifax portal. These portals have been studied that maybe it could violate just a little cephalic, but not the musculocutaneous tendon. And after when we want to fix the graft placement, the arm, make sure that the arm have to be adducted and the elbow should be flexed. Then the 2mm cannulator screw is used to fix. This is outcome. There's no report of nerve injury, and there's a follow-up study at 6 months. There is 16% of graft resorption, but no redislocation after for a patient for 1 year's follow-up. And for a 4-year follow-up, they also improve of the functional score in patient with 92% with good functional score and no recurrent dislocation report in any patients. They'll show the functional comparative study with the Latage, but there is no significant difference of clinical outcome or redislocation or reabrasion rate between Latage and distal tibial allograft group. But in the demographic data, there's just only the significant bone loss in the distal tibial allograft group. Maybe it's just because this is not the randomized control study. In this study, they also report about the 10% of complication length in both groups. Latage, we have the musculocutaneous injury in one patient from 50% in 50 patients, and this allograft group have a traumatic hardware failure and a subscapularis failure, and some patient got persistent pain. Distal tibial allograft have some other clinical applications, just like fell off after the Latage surgery. Dr. Provencher used distal tibial allograft in failed Latage surgery and reported good outcome score. The mean glenoid bone loss before doing the distal tibial allograft is around 30%. Others from the anterior glenoid reconstruction, Dr. Provencher also uses in the post-surgical glenohumeral ankle arthropathy and report in the just only focal chondromalacia at anterior inferior part of the glenoid and report a good function, but this just only one case report. After that, from the anterior part, distal tibial allograft also used in the posterior glenoid deficiency. There's many publications about use in this, and also reports in the good graft incorporation between the glenoid interface and the graft. So for the take-home message, distal tibial allograft give the satisfactory patient reported outcome with a low recurrent dislocation rate. And indication for use, this is the primary surgery in patient with glenoid bone loss more than 20% or high-risk patient, but this have to be selected case and recommend in revision surgery. But the limitation is the graft availability. Thank you.